From current controversies on subspecialty certification to the types of tumors treated with Mohs micrographic surgery, increasing utilization, third-party payer reimbursement, and the appropriate use criteria, it appears further investigation is needed to elucidate and optimize solutions to many of the current controversies associated with Mohs micrographic surgery.
That's Dr. Julie Croley. And this is Dermatology Weekly, the weekly podcast from MD Edge Dermatology. I'm MD Edge editor Elisabeth Mechcatie.
And I'm MD Edge editor Terry Rudd. Today, Mohs micrographic surgery entails many controversies, from specialty certification to the types of tumors treated. Three dermatology residents, Dr. Judy Croley, Dr. Elisabeth Tracey, and Dr. Daniel Mazori, discuss Mohs micrographic surgery for melanoma and other tumors. And they review reimbursement for and the cost-effectiveness of the procedure. They also highlight controversies surrounding the Mohs Appropriate Use Criteria.
In the news, new long-term data show apremilast remains beneficial in Behçet's disease through 64 weeks of treatment. An analysis of national data reveals a significant drop in melanoma cases in younger people, but not among the older population. And Oregon debuts a public education campaign to promote the early detection of melanoma.
You can reach Dermatology Weekly by emailing us at podcasts@mdedge.com. You'll also find that email address in the podcast description.
And now the news.
The FDA recently approved oral apremilast to treat oral ulcers in patients with Behçet's disease. Approval of the phosphodiesterase inhibitor was based largely on the results of the 12-week Phase 3 RELIEF trial. Now there are data showing that apremilast's improvements in oral ulcer severity and patient quality of life remained through week 64 of the RELIEF trial's long-term extension phase. Dr. Alfred Marr is a rheumatologist at St. Gallen Cantonal Hospital in Switzerland. He reported the study's long-term results at the annual Congress of the European Academy of Dermatology and Venereology. At the end of the study's 12-week phase, 178 patients entered the long-term extension. They either stayed on apremilast at 30 milligrams twice a day for another 52 weeks, or they switched to that regimen from placebo. Results in patients who switched from placebo to apremilast were reassuringly similar to outcomes in patients on the drug for the full duration. For example, the mean improvement on the patient-reported Behçet's syndrome activity scale was nearly 19 points after 12 weeks of apremilast, and almost 17 points after 64 weeks of apremilast. Among those who switched from placebo to apremilast, the average improvement was 16.8 points by 64 weeks. After 64 weeks on the drug, improvement over baseline on the Behçet's disease quality of life measure was 3.6 points. But those who switched from placebo saw nearly the same improvement at 3.4 points. At the RELIEF trial's outset, patients averaged 4 oral ulcers. At week 64, those on continuous apremilast averaged 1.4 ulcers, and the group that switched from placebo averaged 0.8. In the long-term extension phase, the main side effects were diarrhea and nausea. Cases were typically mild, and they were roughly twice as frequent as in placebo-treated patients.
Sun-protective behaviors may be having a significant impact on melanoma rates in the nation's younger generation. That's according to a study that looked at trends in melanoma incidence in the U.S. Researchers at the Fred Hutchinson Cancer Research Center and the University of Washington, both in Seattle, analyzed data from the National Program of Cancer Registries Surveillance, Epidemiology, and End Results database for the years 2001 through 2015. They found that the incidence of invasive melanoma among people of all ages increased from about 50,000 cases in 2001 to about 83,000 in 2015. In 2015, only 67 cases were reported in children younger than 10, 251 in adolescents aged 10 to 19 years, and 1,973 in young adults aged 20 to 29 years. Between 2006 and 2015, the annual percentage change in melanoma incidence fell by 4.4% for adolescent males and 5.4% for adolescent females. The incidence dropped by almost 4% among young adult males and among young adult females, statistically significant changes for each age group. But during the same period of time, the incidence of melanoma increased by an annual percentage change of nearly 2% for men and women aged 40 years and older. The researchers caution that the data are observational and thus can't conclusively determine the cause of the decline, and the study didn't have data about potential confounders such as skin pigmentation, sunburn history, sunscreen use, and tanning bed use. However, the investigators conclude that increased UV exposure protection was a likely explanation for the reduced incidence of melanoma in adolescents and young adults, and they add that the data support continuing strategies to promote UV protection throughout life. The results were published in JAMA Dermatology.
In other melanoma news from the Northwest, a program to promote awareness and early detection of melanoma is now underway in Oregon. The state's War on Melanoma was launched earlier this year with the aim of dramatically reducing melanoma deaths. The program includes a media campaign to educate the public about early detection. It also features the release of an iPhone app designed to help users monitor moles over time with photos they can share with their healthcare providers. Another element of the program includes partnerships with state-licensed professionals who deal with the skin, such as massage therapists and tattoo artists. Dr. Sancy Leachman is professor and chair of dermatology at Oregon Health and Science University in Portland. In an interview at the Skin Disease Education Foundation's annual Las Vegas Dermatology Seminar, Dr. Leachman said the project is expected to cost up to $1.5 million over the first 18 months. At that time, researchers will survey residents of Oregon and 2 control states to see if their knowledge of melanoma has improved. And in 5 years, the researchers will begin analyzing melanoma mortality in the 3 states. SDEF and this news organization are owned by the same parent company. We'll be right back after this message. And now, Dr. Judy Croley, Dr. Elisabeth Tracey, and Dr. Daniel Mazori.
Hi, my name is Julie Croley, and I'm a chief dermatology resident at the University of Texas Medical Branch in Galveston, Texas. Welcome to this podcast episode on current controversies in Mohs micrographic surgery. I am joined by my fellow CUTIS resident columnist.
Hi, I'm Libby Tracy. I'm a dermatology resident at the Cleveland Clinic in Cleveland, Ohio.
Hi, everyone. I'm Dan Mazori. I'm a dermatology resident at SUNY Downstate in Brooklyn.
There is controversy on the types of tumors treated with Mohs surgery, most notably for the surgical management of melanoma. What studies have been conducted to assess the use of Mohs for melanoma?
So one institution found that 5-year survival and metastatic rates for 535 patients with melanomas that were treated with Mohs micrographic surgery with closed sections were the same or better when compared to historical controls treated with conventional wide local excision.
Not so much a study, but the appropriate use criteria for Mohs that were published in 2012 by the American Academy of Dermatology and other organizations actually consider Mohs to be appropriate for 10 out of 12 scenarios involving lentigo maligna or melanoma in situ, which I found interesting given the controversy of using Mohs for melanoma, like you just mentioned, Julie. The other 2 scenarios were deemed uncertain in terms of the appropriateness of Mohs, but none of the scenarios involving lentigo maligna or melanoma in situ considered Mohs to be inappropriate.
That is interesting. I'm curious, do your institutions use Mohs for melanoma? What about immunostaining?
So in my institution, we do staged excision with a complete margin assessment for melanoma in situ. The tissue is sectioned like a Mohs section. And then melanomas, invasive melanomas, are treated with wide local excision or managed or co-managed by plastic surgery particularly if they need a sentinel lymph node biopsy or with medical oncology?
My institution doesn't treat melanoma with Mohs or MART1 immunostaining. We do wide local excisions.
Yeah, my institution typically does slow Mohs for the treatment of lentigo maligna. For invasive melanomas, we either treat with wide local excision or refer to our surgical oncology department for management. We don't use immunostaining. While there are growing data for advantages of treatment with melanoma in situ with Mohs and immunohistochemical staining, there are a lot of challenges associated with using these stains in practice, needing thinner sections. It's more time-consuming. About 60 minutes is usually quoted for MART1 staining, cost of reagents, having a high enough volume of cases so reagents don't expire, equivocal cases, education. Only about 17.4% of Mohs fellows have exposure to immunostaining, according to a recent survey. Training, practice, required to interpret margins. So there are a lot of barriers to using immunostaining, but I think it has a lot of potential in the future. Another source of debate is increasing utilization. What reasons do studies cite for this increase?
So there was a retrospective analysis of data from the National Ambulatory Medical Care Survey, so national data that showed from 1995 to 2010, there was an increasing trend in the percentage of skin cancers that were managed with Mohs surgery from approximately 3% in 1995 to 17% in 2010.
Some of the reasons that I've seen cited for this increase include the fact that Mohs has superior efficacy for appropriately chosen cases, and also the fact that Mohs is being expanded to treat other tumors such as melanoma, like we've just discussed, and other tumors like Merkel cell carcinoma as well.
So, Julie, I know that you wrote about the wide variation in mean number of Mohs stages amongst dermatologic surgeons, and that there were certain interventions that were instituted to try to narrow that variation.
Yeah, intervention has been proposed. Notably, it has been demonstrated that mailing out individual reports of practice patterns to high outlier physicians resulted in a reduction in mean stages per tumor, as well as an associated cost savings when compared to outlier physicians who did not receive these reports. So it does appear that some of these interventions may be helpful in the future. Another source of controversy surrounding Mohs micrographic surgery are reimbursements and the cost effectiveness of Mohs. I think that public perception probably mirrors this. An article title in the New York Times theatrically postures, "Patients' Costs Skyrocket, Specialists' Income Soar." The article recounts Mohs patient's outrage at charges associated with the treatment of her quote-unquote minor medical problem and the simultaneous quote-unquote sharp climb in dermatologist incomes over the last 2 decades. What have studies assessing the cost effectiveness of Mohs elucidated?
One study by Ravitsky et al. Showed that Mohs was cost effective. In that study of 406 tumors, they found that Mohs was the least expensive surgical procedure, costing $805 per tumor, as compared to standard surgical excision, which costs anywhere from $1,026 to $2,507 per tumor. That same study also showed that when adjusted for inflation, the price of Mohs was lower in 2009 as compared to 1998.
Yeah, and despite that, Mohs surgery codes have been frequently reviewed by the Relative Value Scale Update Committee and remained on a list of potentially misvalued services for years, according to the Centers for Medicare and Medicaid Services. Reimbursement to perform Mohs surgery and reconstructive surgery has gone down by more than 20% in the last 15 years, at least in part as a result of this scrutiny. The
Mohs Appropriate Use Criteria has been debated as well. What are some of the pros and cons of the guidelines cited by others?
One common criticism is that the studies utilized in the development of the AUC were all from the United States.
In addition to that, Steinman et al. Criticized the AUC for classifying most primary superficial basal cell carcinomas as appropriate for Mohs. Since they published their criticism, one of the AUC co-authors and others have defended that classification. Ruiz et al. Criticized the AUC for not considering variables such as operating on multiple tumors on the same day and operating on a tumor that is incorporating into an adjacent wound. In addition to that, the AUC have been criticized for being largely based on expert opinion rather than evidence.
Others argue that reported discrepancies further point to the importance of clinical judgment and call into question the need for further revision of the criteria in the future. For example, a primary squamous cell carcinoma in situ greater than or equal to 2 centimeters located in the L distribution of a healthy patient is categorized as appropriate, while a recurrent but otherwise identical squamous cell carcinoma in situ is categorized as uncertain. These counterintuitive criteria are unsupported by existing studies, and so people have called into question the need for further revision of the guidelines. Another topic of debate has been subspecialty certification in micrographic surgery and dermatologic oncology. This was approved in October of 2018. However, there was a lot of debate surrounding its approval. What opinions have people argued in regard to subspecialization prior to approval?
So historically, this has been a split issue. When members of the American Academy of Dermatology were surveyed in 2017, 51% of respondents were in favor of certification and 48% were against certification, so pretty much split down the middle. Proponents have argued that certification could bring more consistency and decrease divisiveness among dermatologists, that it could also help prevent exclusion of Mohs surgeons from insurance networks, and could also demonstrate competence to patients, the media, and payers. Opponents of certification have argued that it could disenfranchise many dermatologists.
I suppose time will tell as far as how it all plays out. From current controversies on subspecialty certification to the types of tumors treated with Mohs micrographic surgery, increasing utilization, third-party payer reimbursement, and the appropriate use criteria, it appears further investigation is needed to elucidate and optimize solutions to many of the current controversies associated with Mohs micrographic surgery. My name is Julie Croley. Again, thank you for joining us on this podcast on current controversies in Mohs micrographic surgery. Join us next month for another resident takeover.
And that concludes this week's episode of Dermatology Weekly. To get past and future episodes of Dermatology Weekly, subscribe now on Apple Podcasts, Google Podcasts, Spotify, YouTube, or wherever you get your podcasts. I'm Terry Rudd.
For Dr. DeLeo, MD Edge editor Melissa Sears, and all of us here at MD Edge, I'm Elisabeth Mechcatie. Thanks for listening.